Dr. Shrivastava is currently an assistant professor and stroke neurologist at Hamilton General Hospital and McMaster University. He is also the assistant program director of the Adult Neurology Residency Program and the clinical lead for stroke prevention clinics at Hamilton General. He did his medical school, internal medicine, and neurology training at Delhi University in India, followed by a 2-year stroke fellowship at McMaster University. His research interests include acute stroke care, quality improvement in stroke healthcare delivery, and neurosonology. And so I'd like to turn it over to Dr. Shrivastava.
Hi, Tina. Thank you so much. Sorry, my Teams was upgrading at the same time, so log out. It doesn't allow me to share.
All right, I can change that.
Oh, there we go. Magic happened there. And let me see. Sorry, I'm just not the most comfortable with Teams. It takes me always a few minutes to figure it out. It's
no problem.
Let's see. And hopefully I am able to just. Okay, can you see my slides?
Yeah, it's perfect.
And it's moving too, right?
And it is, yes.
Perfect. Yeah, good morning, everybody. I'm trying to figure out what the best way is to see everybody at the same time, and but everybody actually has their cameras off, so I'm just seeing a barrage of icons and no faces, so I have no idea if what I will talk in the next 1.5 hour, if that makes sense, or if it just all bounces on top of everything that's going on. So if anybody wants to, please, more than welcome to open your camera so that I may know through your reactions what's happening. We typically like to do these in person, where it's much more easier to know what's going on, and if I need to amend my ways of what I'm talking about. But let's see how we do this over Teams. Okay. So thank you, Tina, Rhonda, Steph, for both inviting me here, and then always great to follow Rhonda and Steph because you make my job easier about things that I thought, oh my God, how will I explain this complex thing? And then you've already done it in a beautiful manner, so that in itself will make my talk a lot more easier to flow through. However, I did intentionally, because again, interaction, I wanted to keep this as interactive as possible. However, it's harder to do that on a virtual format. So I've tried to keep my presentation short, and then I'll leave some time at the end so that if anybody is interested with any questions, I hope you have a few, and we can always go over them. If I do ask some questions in the meantime, feel free to unmute yourselves and take a shot and see so that we can have some discussion ongoing. Okay. So, Tina already sent out some great objectives. I removed the whole objective slide from my talk because we are going to talk about the hyperacute stroke journey for our patients. Rhonda and Steph gave you some very good patient stories, and I will give you a story of my own. This is Mary, a 72-year-old lady who was from home, stays at her home with her partner, completely healthy, no major medical issues in the background, and then she had an uneventful night last night and then went to sleep. Partner didn't notice anything overnight. He woke up earlier in the morning, went down, made coffee. And when he was making coffee, he suddenly heard a thud upstairs, rushed back up and he found Mary on the floor with dense right-sided weakness and inability to speak. This happened at around 10 a.m. and he called 911. So this is once stroke symptoms have been recognized, that's when our journey for a patient begins. Now, next is what you guys do is when you go on scene, you assess the patient, you determine this is potentially a stroke, and you bring them to Hamilton Health Sciences in our case, or whatever is the nearest stroke center for you guys. And then because of your pre-notification, more often than not, we are already there at the scene. And we do a quick TOA, okay? So the important, that's probably the most important step in this patient's journey is what happens during those quick 5 minutes, right? We don't have any family in ED. You are our only source of the patient. The patient may have a medical chart in our system, may not have a medical chart. Like this patient, if they're super healthy, they haven't had really any family, any other medical system visits apart from their family doctor. They may or may not have their medications on Clinical Connect. So honestly, you're probably the only source of info that's coming to us. And if we are able to optimize that information and do it in a quick manner, we will be able to help make treatment decisions for this patient in timely manner as well, right? Every minute, however, here counts, because every minute a patient's having a stroke, there are about 2 million neurons that are being lost, right? And what our goal is what Rhonda was trying to explain, is there's obviously some tissue of the brain that's dead almost immediately. However, around that dead tissue, Tina, can you see my cursor too, or are you just seeing my slides?
I just see your slides.
There's no way you can. Let me see if I can use a pointer, maybe that. Okay, can you see that now? Can you see my pointer or still not?
No, I'm sorry, we can't.
Okay, let me try one more thing. You can still see my slides, right?
Yes.
But you still can't see my pointer or anything?
No, unfortunately not.
Oh, let me, now?
No.
Still nothing. Never mind. I will stop trying to game MS Teams and go back to my usual path. What I was trying to show was the black area is already infarcted tissue, whereas this blue area is, or let me try just one more thing, okay? Sorry, one last thing, sometimes that helps, is, can you see my pointer now?
Yes. Yes,
Okay,
I can.
yes, thankfully. So what I was trying, but I might have to minimize everything else because now my whole screen is sharing. So so this blue part is what we call the penumbra. So this is the part of the brain which is not yet dead, but is dying. And that's the goal of any stroke therapy or revascularization or hyperacute stroke therapy, is though we can't do much for what is already dead, if we can save this not yet dead but dying part, that's how we are going to impact change in the patient's outcourse or change in the patient's trajectory. Okay. Now, the first, as I said, the first point of contact for the patient is you guys. And then when you come to ER, we are looking for some very quick information. And I tried to distill that as the 5 T's. The first and foremost is time last known well. Okay. So not when stroke started, this is when the patient was last seen fully normal. Okay. This may or may not coincide when the stroke symptoms started. So in Mary's case, the husband thought that she had an uneventful night and she was okay till morning. And then when he heard the loud thud, he called 911. And so he thought that her last known well was probably 9:30 p.m. or 10 p.m. But in reality, we don't know what happened overnight with Mary, right? Did she have a stroke at night and she was on bed, and when she was trying to get out of the bed in the morning, the first thing, that's when she fell? Or did she really truly have a stroke at 9:30 p.m.? We don't know. So when we don't know, we always take the time as when the last fully functional patient was witnessed by somebody in the family. This may be hard. If the patient's living alone, you may not be able to. Sometimes you may be able to piece out, say if a patient spoke to somebody in family or somebody over the phone, or if somebody shot a text or things like that. We're often playing Sherlock Holmes in trying to figure out what the last known well is. But sometimes we do not have a clear last known well, or as in Mary's case, we don't know when the stroke happened. Did it happen overnight or did it happen in the morning? Even though the husband thought that she had an uneventful night, he didn't really speak to her. He didn't really see if she was moving her right arm or right leg. So the time last known well is the most important thing that we need information when we are getting handover. Okay. As I said, it may or may not coincide. So if there's a family member who saw a patient who was completely fine, then went out and did groceries and then came back and found the patient with deficits, the last known well would be before they went for groceries. If, however, somebody is walking, talking, and suddenly in front of you, they have sudden inability to talk, or sudden inability to move their right side or something, then that is a witnessed stroke onset. However, whenever we hear the word witness stroke onset, I always like to ask the question, what was the patient doing immediately before? So were they even talking? Sometimes when we get up, we don't really start talking or shouting to our family members immediately, right? So we don't even know if they were talking before that, were they walking before that. We want to know completely fine when they were. Okay. And the key important thing is to decide what can they be eligible for thrombolytic therapy. So are they within 4.5 hours or are they more than 4.5 hours, which is how our hospital will send out a pre-notification as well after your batch. So very, very important. First T, time last known well. The second thing, and this again, when you're on scene, there's always a rush to get the patient fast to ED. However, always remember you are in contact with the patient's family. The patient may not be in a condition to talk, or he may be altered, or he may be confused. But you were there with family, and you have this maximum chance of getting good information. When the patients arrive, we open the charts, we call the family members. They're either driving or they're not picking up the phone, or the number's incorrect on the chart or something of that sort. So often we have to rely on what you tell us. So the second thing we want to know was when the symptoms started. If it was a witnessed onset, was it sudden in onset? So it was completely fine a moment back and suddenly developed droopy face, arm leg weakness, speech problems? Or was, oh, she was unwell throughout the day and she wasn't really talking much throughout the day? Or was her arm was weak in the morning and her leg was weak in the afternoon? Or they thought that her hand was weak initially, and then over a few minutes her arm became weak, and then over a few minutes the face started becoming weak. So every line in that tempo of onset is very crucial. Sudden onset is usually vascular. Onset over a few minutes or seconds is typically something else. So if you have something which begins in the hand, then goes on to the arm, then goes on to the face, then goes on to the leg, Can be seizures if it's happening over seconds, or it can be migraines if it's happening over a few minutes, or can be a whole lot of other things going on in the brain, especially if it's progressing from one part of the body. So the one question we always ask is, did the face, arm, and leg weakness happen all at the same time, or was it the face first, or was it arm first, or was it leg first, or was there any progression of symptoms or not? And what was the onset accompanied by? So is there any twitching at onset? Did they notice any seizure-like activity or tremors? Did the patient lose consciousness at any point of time? The moment patients had loss of consciousness, that is very, very important information, because then the chances of that being a stroke actually start reducing. And very, like, maybe only one stroke is where there's some decreased level of consciousness. But in most strokes, level of consciousness is usually preserved. And if somebody's had a syncopal event, so if you've lost consciousness and then you've regained consciousness and you're then manifesting with stroke symptoms, the chances of that being a stroke are actually lower, and the chances of it being something else actually increase. So very important to know, did it all begin at once, or was there some sudden, was there some progression of the weakness or progression of symptoms over a few seconds, over a few minutes, sometimes even over a few hours, and was there anything else that was happening at the same time of onset? Okay. The third thing that we want to know, because we want to base our treatment on that, is, are the patient on any thinners? And we're not talking aspirin or Plavix. We're talking about any blood thinners like Coumadin, warfarin, or Pixaban, Rivaroxaban, Edoxaban, Dabigatran, the newer generation. So what we call the DOACs, the direct oral anticoagulants, or Coumadin, or sometimes patients are like cancer patients or some other patients who maybe have clots in their legs, they may be on injectable thinners. So most patients would often know. Of course, if you have a med list, that will be great. But most patients usually know if they are or not on thinners. Of course, great if we have the whole medication list, that's amazing. But if they are on thinners, that one key line in your TOA, not on any thinners, has a lot of weightage in our minds. And as soon as I hear, oh, patient is on a thinner, my urgency for treating does drop a fraction, because there's slightly lesser things now that I have to offer for the patient. However, if you say no thinners, my vigil is as high as it's going to be. If, however, you do go on scene and you hear the patient's on a thinner, the patient tells you on a thinner, another important information that I need is, when was the last dose of that thinner? Okay. Did they take it the same morning? Did they take it the night before? Did they take it the morning before? Have they not taken it for a few days for some reason? Have they been very poorly compliant with their medications? Again, it's going to frame my treatment strategy. So very, very important to know if on thinners, and if we're on thinners, when was the last dose? Now, the next question that I'm going to ask in my rushed handover is, how is the patient typically at baseline? Are they fully independent? Are they bedbound? Are they on a walker? Are they ambulatory? Are they not ambulatory? Do they have severe dementia, because of which all their activities need to be done by the family? Are they from a nursing home where nurses are taking care of them because they need constant medical attention? What is their background? Is there severe medical issues? Are there a lot on some meds? A lot of things, right? So that's the typical baseline function. The one important word that I want to hear is how independent they were. Were they independent at baseline, or were they severely dependent at baseline? And again, the reason for that is, as we'll discuss later in the presentation, is we want to see what kind of treatments can we offer for these patients, and that depends on the level of independence, right? You can't make a patient better than what they are at baseline. So in using our resources and in using our treatment options that we have, we always like to know how the patient's been doing at baseline. And the one and only test that we need on TOA, again, great if you give us vitals and stuff like that. If you have an IV line, amazing. But the only test that we need is what was their finger prick glucose or sugar. Because sugars are hypoglycemia is the biggest mimic of stroke. Any patient can have a low blood sugar and behave exactly like stroke. Often clears up immediately as you give either glucagon or D50 or anything, and sometimes we've had patients activated as code strokes. By the time they've reached our ER, you've already treated them in the periphery with D50, and by the time they're here, they're all happy and cured from their stroke. So the only test that we ever need before we are thrombolizing somebody or we are doing definitive treatment is glucose. We do send a barrage of other tests, and we may or may not get back some of those results. But the only thing that is a must to have before we get our treatment decision algorithm in place is what is their blood glucose. If it's too low, have you treated it or not? And if it is too high, it's something that I place in the back of my mind as does this patient need a little more monitoring because there's a higher risk of harm, but not as important to know as if the glucose was low. So time last known well. How did the stroke start? What was the tempo of onset? Was the patient on any thinners? What is his typical baseline? And what was his test of glucose in the periphery or in the at home or wherever the patient was picked up from? So that's me. The Canadian stroke. So this Canada has some of the best stroke best practice guidelines, and it's all freely available online. It's a very good resource for every time. I still almost refer it weekly to see up something that I've forgotten or see something more for clarification. What best practice guidelines recommend for EMS transfer is on scene time with any suspected stroke patients, you should target a median time of less than 20 minutes. Okay, so I know I want a lot of information on TOA, but you don't have a lot of time for that. In those 20 minutes, you have to get the patient out, make sure that they're stable. There's not something super urgent that needs to be done to protect the airway or breathing or anything else. I want your capillary glucose in that time. And then while you're on the way, I also want all that information on a patch. I know in our province, we can't really give a lot of information or patient identifiers over radio, but there are some places where you can give a lot more information, but at least information enough that I can, or my charge nurse in the ER can trigger a code stroke. Or if she has any questions, she'll call me and ask me if you want me to trigger a code stroke, because once we get that trigger, we're all on our way and hoping to be there before you guys come so that we can minimize any time lost, right? So that's the best practice guidelines. It's a very structured one. And again, I'm going to go over as to what they want for us. But if you remember the 5 T's, that's usually more than enough. And I don't think anybody else would want any more information. Of course, the things that I assumed are also included. So if, as I said, some provinces might have the ability to transfer this over patch, but not ours. Where is the patient, stroke symptom onset time, if witnessed, last known well time, if not witnessed, total symptom duration at anticipated arrival in the ED, how far you are out, presenting signs of stroke. So is it just a mild droopy face? Is it like a full arm leg weakness? If you've used a screening tool like LAMS, what the LAMS score or things. What is the current condition? Is he stable? If they're like super hypertensive, if they're breathing very shallow, or they're something very urgent going on, they needed to be intubated on scene, for example, or what the previous functional status, so typical baseline and typical independence level at baseline, and what's happened right now. current medications, or as I said, thinners, if they are on, and what was the last time that they took the Thicken. Advanced care plans, always a good question to ask just before you're rolling out is, do they have a DNR in place, lest we start doing something very aggressive against the patient's wishes. Again, expected time of arrival at the receiving hospital, including in-scene time. And if you have a medical history, if you could get that in the 20 minutes, any medications or something, that will be great. Okay. But if you go back to this slide, is if you need to just remember the best practice guidelines might be a little hard to remember everything. Now, the reason we are all rushing, as I said, time is brain, what's going on, it's because we want to be taking a quick decision whether this patient is eligible for any hyperacute stroke therapy. And that's the 6th T. Is he eligible for any thrombolysis, or is he eligible for any thrombectomy? Okay. As Rhonda and Steph said, our provincial, we are the regional stroke center at Hamilton Health Sciences, and we want to help as many people in the province as possible. Something's happening with my screen, which I don't know. Yeah, maybe that's so. So we want to be able to make those decisions very quickly. We don't have time to waste. We don't have time to take a detailed history, do a full neurological examination for hours, figure out if this is a stroke or not, and then treat at our leisure. We have to do it in a very time-bound manner. So once you've given the TOA to me in ED, my brain starts thinking immediately, is it a stroke or is it a mimic? And by mimic, I mean like seizures or brain tumors or demyelinating attacks of MS or migraines or something known as amyloid spells or bleed inside the brains. So my first step immediately goes, am I dealing with a stroke or is it something non-vascular or non-stroke? I've gotten my history from you guys already. If there's something more that I want, I'll call the family if they're reachable. Then what we do is what Rhonda mentioned, right? The NIH stroke scale, or the National Institute of Heart Stroke scale, which is a very quick, tailored, structured exam to pick up stroke deficits in a timely manner. As I said, if you armchair neurologists, or when we are in our clinic, our neurology exams can take hours. When we are in the thick of things, we want this to happen immediately. So we do our NIH, we have a quick look at the vitals, make sure that the patient's okay. And already in my mind, I'm beginning to work on that, my pathway of this looking like a stroke, is it looking like something else? If it is looking like stroke, then the next step is to determine as quickly as possible, is it an ischemic kind of a stroke or a hemorrhagic kind of a stroke? So has there been a clot in the brain which has blocked off blood supply to a part of the brain and that's causing ischemia, versus is there bleeding inside the brain and that's causing hemorrhage? Okay. Brain hemorrhage, very different treatment and very different things that I want to be focusing. Ischemia, I want to be getting back to my 6th T. Is it there possibility of thrombolysis or thrombectomy in these patients, right? There are some clinical clues, of course, but none of them are super reliable. But yeah, there are some clinical cues. Sometimes if we have a very quick decreased level of consciousness, if we have very high blood pressures, seizures and stuff, we start thinking, oh, this must most likely be a bleed and we can have some time to ourselves. But no, A, bleeds are equally urgent to be treated as ischemia, and B, we've been wrong multiple number of times, and patients like with the basilar kind of a stroke or cortical strokes can always present with seizures, super high blood pressures, decreased level of consciousness. So the only thing that can truly reliably differentiate between the two is a STAT, what we do, a CT-CTA stroke protocol. Again, thankfully, Rhonda covered this. So a plain CAT scan, something that looks like this, and the CT angiogram, which is where we shoot a dye through their veins, and then we're looking at the blood vessels to see if there's any blockage in the blood vessels, or if it's a bleeding kind of stroke, is there any leakage from the blood vessels. And By the time I'm in the scanner with the patient, the next question, which I've already kind of started answering in my mind, or I'm trying to answer very quickly, is this patient eligible for TPA or TNK? As Steph said, we've now switched from alteplase to tenecteplase. And if he is, my goal is that I should, from the moment the patient comes to ED to the moment that I push the thrombolytic in his veins or her veins, is less than 30 minutes. All right. So you have 20 minutes on scene. I have 30 minutes with me in which I gather, is it a stroke versus mimic? I quickly run over to CT, put them on the CT scanner, get the CT done, rush them back to ED, and then push the drug, dissolve the drug and push the drug. So there's a lot that needs to be done. And that's why every step in this machine has to function very smoothly if we can get our times to less than 30 minutes. Okay. And then the last step that I'm looking for is what we call an LVO, or a large vessel occlusion. Is, does this patient have blockage in one of the major arteries of the brain, like the middle cerebral artery or the internal carotid artery or the basilar artery, or the one of these, or in combination? Because if there is a blockage in one of these arteries, then as Rhonda showed, we have a treatment that we can offer to them that is going to change their lives completely, that we didn't have till before 2015. Unfortunately, these were the worst kind of strokes and we didn't have the best treatment. Our thrombolytic, which is great for our smaller strokes, didn't really dissolve these big clots in more than 10% of cases. So 90% of those patients would still have that clot, will still continue to do poorly. And then we got a spate of trials in 2015, and then we got that added boost in 2018 when we could treat them for longer. If that is the scenario, the goal for that is also less than 90 minutes. Now, the less than 90-minute goal is identifying that the patient has an LVO or a large vessel occlusion, getting them back to ED, pushing the thrombolytic, getting the EVT team, which is a separate team, a neurointerventional team, into the interventional suite. They may not be there because, right, the pre-activation doesn't reach the EVT team, right? If for some reason they're not in hospital, when I call them, oh, I think there's an LVO, that's when they get activated and that's when they start moving in. And so they come, they prep the angio suite, we get the patient in, they clean and drape the patient, get all their instruments out, and then eventually start the process of going into the brain by that groin puncture. So we call this door to groin puncture time. And this ideally, if a patient's presenting to our ED, should be less than 90 minutes. Okay. So these are the median time goals that we want to target in this patient. Because of that whole, every minute the blood supply is cut off, we're losing 2 million neurons. Okay. Now, before we go into a little more detail, I just thought we'll look a little back now, pre-1995. And I don't know if Dr. Salis has already joined us in the call, and he took a beautiful talk once when he described how stroke care has evolved, right when he was a resident or when he was a med student, when we didn't have any big therapy for stroke patients. And if you had a stroke, you were just lying on the ward with aspirin and just waiting to see if you had any spontaneous recovery, or are you going to just be paralyzed or dependent for life. Then December 14, so in another couple of weeks, this would be the 30-year anniversary of this paper, right? 30 years, right? Yeah. My God, it's been such a long time. 30-year anniversary of this paper. So this was the original. Now, they were experimenting with things like clot-busting drugs in the 1950s. But this was the first time when there was a planned treatment trial that happened in patients who had strokes, where they were given this medication, which is a clot-busting drug, to half, and then half got the usual standard medical care. And what they found that when you did this, there was a significant improvement in the patients who received the clot busting drugs. Now, before I explain this slide, let's just quickly talk about two terms that I'll be using a lot in this presentation. Um, Not so much Barthel index. Barthel index is a very detailed functional score of a patient. So decides how independent a patient is, and it's a lot more detailed, it's a lot more cumbersome, it takes a lot of time, but we get a fairly good idea what the current functional level of the patient is and how independent that patient are. What we do often, much more often actually use in the stroke world is what we call the MRS, or the modified Rankin score. And the modified Rankin score is a 6-point scoring. Begins with 0, which the patient's completely independent, no symptoms, completely healthy. MRS1, where they may have some slight symptoms, but nothing major, no significant disability. They're able to carry on everything that they were able to pre-stroke. MRS2 is when they have some slight disability, residual disability from the stroke, and they're not fully normal prior to the stroke, and they may not be able to do some of the activities, such as driving, or they were able to run before, or they were doing something that they're no longer able to. However, they're mostly independent. They're able to walk on their own. They don't need any gait aids or any supports. Now, MRS3 is when patients have moderate disability. So now we are dealing with patients who have some residual things from the stroke, probably need rehab, or this is their status after rehab from a very severe stroke. They've now improved to this level. They might need a walker or a cane, but they're still mostly ambulatory on their own. Okay. And till this point, so MRS3, the main thing is that they're ambulatory, even with gait aids, like a walker or cane, they're still ambulatory on their own. MRS4 is when this disability is very severe and they need a lot of help with their basic daily activities. Even for walking, they may need a person support or 2% support along with a gait aid. They can be left independent, like for a few hours at home without needing to be on their bedside 24/7. But they won't be able to look after their basic activities of daily living on their own. Then MRS5 is what we call severe disability or bedbound state, or a patient who can't really do anything on their own, can't be left for a few hours, more than a few hours at any point of time during the day, and are dependent on everything like their toileting, feeding, everything's dependent. And MRS6 is death. Okay, so a 6-point scale from 1 to 6, which helps us define how the patient's done pre versus post his stroke. So when they did the analysis of the NINS, we call this the NINS TPA trial. So they saw the NIH significantly better in the TPA group. Barthel index, which is that functional score, the 95 to 100 is the full functional score. See how the TPA arm about 50%, only 38% in the placebo arm. MRS, which is our usual endpoint in most of our stroke trials, about 39% had an MRS of 0 to 1. So no symptoms to mild symptoms, no disability. So, and if you look at MRS 0 to 3, so almost 60 patients, 60% of the patients had MRS 0 to 3, almost a 12% benefit over patients who did not get the drug. So significant improvement in their 3-month outcomes after the drug. And then the other thing that they looked at was GCS, not something that we commonly look in the stroke world, more for trauma and neurosurgery, but even there, the patients had some significant improvement. So number needed to treat. Another thing that we look for all treatment interventions is how many patients that you need to give the drug for one patient to do significantly better. So the TPA had a number needed to treat of 8. So if in 100 patients you treated, about 12 patients will do significantly better if they got the drug versus if they didn't get the drug. So that's an absolute number and about a 30% relative risk reduction, right? So you were odds of doing 30% better. Now, how is that happening? Now, because what happens is, sorry. Now, TPA is or TNK, both of them are approximately the same thing. These are what we call clot busting drugs. So a clot has formed at a site in the brain, and that clot is composed of these fibrin threads. Okay, some coagulation cascades were triggered in the brain, and then the clot formed, and these fibrin threads all interlaced with each other, and that form that thick structure which is preventing blood flow. No, the body has an intrinsic mechanism to take care of clots, right? That's known as this enzyme, which is known as plasmin. Okay. However, the body keeps it really under check because if there was some uncontrolled plasmin in the body, no clot would form anywhere. You will never get bleeding stopped, and you will be oozing from all your orifices constantly. So this enzyme is usually very significantly underchecked. What TPA or tissue plasminogen activator does is it binds to an activator of this enzyme, activates this enzyme, and this enzyme goes to the site of clots and then tries to dissolve these threads. And then once these threads are dissolved, we call them fibrin degradation products. And so from this thick clot, they go to this loose clot and then eventually broken down completely. And so blood flow can be restored, right? It's the same thing with TNK. When we talk about TNK, I'll let you know what the differences are. So 1995, we get this amazing treatment that we have, which is going to make a difference for the first time in the patient's lives, right? No treatment comes without its share of risks, right? So this is a clot busting medication. As I said, if that plasmin gets overactivated, it can dissolve normal fibrin threads in the body and can cause bleeding in the body, either in the brain or elsewhere in the body. So that was the biggest concern, that this medication led to bleeding inside the brain or bleeding elsewhere in the body. So from more trials, then more and more trials came out. NINS was the original one, then came the ECAS and stuff. What we tended to, when we pooled all the data together, we saw that some or any hemorrhage can happen in about 6 to 8% of patients, but that's not important. What we were targeting is what we called symptomatic intracranial hemorrhage. So what symptomatic intracranial hemorrhage was that if you have a bleed after this clot busting medication and you clinically worsened from what you were, so instead of improvement that we were hoping, you actually became worse. So that's what we call a symptomatic ICH. And we saw that the rates of symptomatic ICH were about 2% with this medication. Now, because these numbers are a lot to interpret, one of my teachers always used to show me this infographic, is that if you treat 100 patient with TPA or TNK, almost these many, so that's 13%, will become completely normal. Let's MRS 0 or 1. So completely normal to slightly better. Okay. All these patients that are in the lighter green shade, so about 19% extra, are going to be better off than what they were. Okay. So some treatment improvement has happened in these about 32% of patients. All these patients in white haven't improved, but they haven't worsened. So you're not made any difference in their trajectory, clinical outcomes or anything. And then of them, about 3% or 2 to 3%, as I said, 3% are worse. And of those 3%, 50% or one of them will actually be either dead or severely disabled. Okay. So overall, this is the figure that you're looking at. And when you look at it from this perspective, you see you're either mostly going to do good for the patient or may not, definitely not do any harm. And of course, because you're dealing with something that's so disabling as a stroke, you do take the risk of patients may worsen, but the risk is not very high. About 2% of the patients will worsen. But if they do, they tend to do poorly. Now, the whole time is brain, I keep harping on that time is brain thing is also very important because how well the patient does after a stroke is dependent on how quickly you were able to get that clot busting drug in them. So these are the odds of a patient improving. If you see this middle is the mean and this is the confidence interval. So it could range from anywhere from here to here. The earlier you get, the better their odds are of treating. And even like a half an hour delay in treatment keeps on reducing that odds and odds and odds and odds. And then from a lot of day trials, we got this number that up to 4.5 hours, there is still some benefit that you will get of treating, but beyond 4.5 hours, you start losing that benefit, and some patients might actually not improve at all, or there may be some harm. Right, so that's how this magic number. This is number of patients, number needed to treat, or number of patients who will benefit per 100 patients that you treat. The earlier you treat, the number of patients who will benefit will be significantly better. In the late window, like 3 to 4.5 hours, there's still some benefit, although the number that will be harmed by the treatment will also increase. And beyond that 4.5 hour mark, you see how that graph flips, and the patients that will benefit will be actually very few, and the patients that will be harming will be actually much more. So everything is time dependent. So when we act like crazy lunatics in the ED, pushing everybody and shouting at everybody, just fast, 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 people think you're like completely crazy people. I think I have no friends in ED left, but the reason is that every minute truly counts, and there's so much data on that that's been drilled into our brains that the chance that this patient is going back to their normal life and driving versus this patient's going to be on disability for the rest of their life, or this patient's going to be long-term care, is all a mere how urgent you were in ED and how quickly were you able to push that drug in for the patient. Now, as Steph pointed out, provincially we switched from TPA, which was our original 1995 Wonder Boy, to this new kid on the block, which is tenecteplase, right? Now the main difference between it is when we gave TPA, it was a little more cumbersome. So if you say had to give like 100 milligrams of TPA, or the maximum dose was 90 milligrams, if you had to give 90 milligrams of TPA, you gave about 10% of that as an IV bolus, so immediately, and then you pushed the rest of it over infusion over an hour on an infusion pump. Okay, so just imagine, I'm talking about we need to do everything in 30 minutes, and here we had to prime a pump, load the medication, load a syringe, infuse the pump. And these are not easy pumps. I don't know how our nurses do it. These are crazy difficult pumps to, and Rhonda can speak to that, how to, get the pump primed and how to get the drug inflowing. So there was a lot of crucial time that we were losing in this whole process. And as you said, only 10% of the drug is going in immediately, right? And the rest of the 90% of the drug is going over 1 hour. So the full benefit or the full level of drug that reaches the patient is still going to take 1 more hour from when you start. So not ideal. So then the pharmacists came up with this new molecule, which is not called tenecteplase. Now there were two differences in tenecteplase. One was Again, as I said, body has a lot of mechanisms in place, right? To what if this plasmin gets overactivated? So there's something known as a plasminogen activation inhibitor in the body, so that if there's anything like TPA or something that we pushed into the body, this goes and binds to that and degrades that. So that's why TPA had a half-life of about 4 minutes. If you didn't give it as an infusion, the body will quickly remove everything from your blood level. Tenecteplase was resistant to these plasminogen activation inhibitors, and so it had a longer half-life. And what a longer half-life theoretically does for us is you don't need that infusion. You can give it as a single bolus over a minute and you're done with. You don't need that whole pump thing and priming and infusing and waiting 1 hour for the whole blood to go in. The second benefit that what TNK had over TPA was that they saw in vitro it was only going and binding to the fibrin in the clot, and it was not going and binding to fibrin elsewhere in the body, right? The body has plugged all our vessels and all our holes and everything with fibrin tapes, and it was leaving all of that intact, and it was only going specifically and binding to the fibrin at the point of interest. So the theoretical risk of bleeding or systemic bleeding was lower. However, what we wanted at that point was, if we switch to tenecteplase, is it going to be as good or better? Or even if it was a little worse, the benefit that we were going to get was so much that we were okay with that. So that's why we did this practice changing trial across Canada. One of our sites and some of our colleagues were on in this trial, and I was a fellow at that time when we were having this trial. It's called the ACT trial, and what we did was we checked this. Is tenecteplase as good? The question wasn't, we weren't asking, is it better than TPA? The question we were asking was, is it as good as TPA, or maybe even a slightly bit poor? And we were okay to that. Say the example that my colleagues often give is, say if you have love coffee from a place that's right down the street, but you love coffee from a point across the town even more, you'd probably end up going to the coffee place across the street more often than not, as long as the coffee is not too bad, right? If it's okay, the benefits of just going across the road is so much better than going across the town. So that's all we were looking for. The benefit of a single bolus dose and reduced bleeding was so promising that we were looking at if it was as good as TPA and the trial. So again, I'll be talking a lot about, so these are the MRS bars, right? The MRS 0, MRS 1, MRS 2, MRS 3, 4, 5, 6. And what we did see, not just as good, maybe even a tad bit better, but definitely not worse. So once we had this data that this was as good as alteplase, we switched provincially to tenecteplase. So with that background, we want to see what these patients. Actually, I thought I'd be going faster than this, but I'll speed up a little so that I leave some time for discussion. Now, who are these patients that we are wanting to thrombolize, right? So the first thing that we discussed was these patients should have a last known well, not stroke onset, a last known well within 4.5 hours. My provisional diagnosis for these should be an ischemic stroke. We've confirmed that on a CT that there's no hemorrhage. The main purpose of us doing a stat CT is to make sure that there's no hemorrhage. Then came a new rider, which initially we weren't sure of, but now a lot of trial data confirmed that these strokes should be significantly impacting function or disabling strokes. Because if you had very minor strokes and non-disabling strokes, say only a facial droop on the left, that's not going to do any harm. That's going to improve over the next 3 months, right? And you're going to push a clot busting graft that has a 2% risk of bleeding. So you don't want to subject a patient to that risk. So a lot of data came for minor non-disabling strokes that if you give TNK to them, you're actually doing harm. So the guidelines change, the stroke has to be disabling. So for a driver, that may be even a visual field, a stroke causing a visual field impairment. For pianist, that may be a stroke causing minor finger weakness, or for a lawyer, that may be some causing speech problems. So either disabling, or if it's a big enough stroke that the scores that you're getting on the NIHSS stroke scale is more than 4. And the last line, as we discussed, it should still be within goals of care. If a patients have expressed wishes, they don't want any treatment, they want only for comfort, then we can't really offer them. So these were the only inclusion criteria. The only exclusion criteria which stands from when the trial came out in 1995, they had about a 3-page long exclusion list for patients, because at that time our goal was to handpick, cherry pick patients, show some benefit, and then start using this drug in real world. However, that's boiled down to only 2 things. If there's any active bleed in the CT brain, so if the scan that you do shows any hemorrhage, you can't give a clot busting drug at that time. Or if there is anything that the patient will bleed significantly after the IV thrombolysis. So that maybe they may have had cardiac surgery 2 days back, they may have a bleeding diathesis, they may have been on DOAC. So for example, if the patient took his apixaban in the morning, or if the patient is on Coumadin and his INR is more than 1.7. So those are the actual absolute contraindications. Everything else that the NINS TPA used has now become a relative contraindication, and you have to use your judgment to see are you still going to go ahead with thrombolysis or not. Of which the one thing that we discussed in detail was make sure that you have a glucose before pushing in the drug, because hypoglycemia can be such a close mimic. Okay. But the only thing to remember from this is any active hemorrhage or anything that increases the risk of bleeding after you push the IV thrombolytic is what you want to rule out quickly. When I get that TOA from you, or when I call that family, I want to make sure that there's no contraindication to bleed. So that's happened from 1995 to 2008. In 2008, the treatment window for TPA increased from 3 hours to 4.5 hours. And then from 2008 till fairly recently, not a lot was happening in the world of IV thrombolysis. However, 3 things happened. One, in 2018, as I said, last known well, very different from stroke onset. What if the patient was sleeping, like Mary, our patient that we spoke about? She was sleeping and we don't know her stroke of onset time. It could have been at 7 a.m. It could have been as soon as she went to sleep. So an option came that you can use MRIs to differentiate what that time of onset was, and there were certain sequences on the MRI that help us pinpoint where the stroke happened and if it was still within that 4.5-hour window. So we came the option of treating wake up strokes. It's harder in our setting where MRI is limited and it's not easy to get. However, a lot of places in the world have switched to an MRI based protocol for patients with wake up strokes. Then came the question, can we extend the window even beyond 4.5 hours? There was some suggestion that up from 4.5 to 9 hours, if you use the advanced imagings that Rhonda was talking about, like CT perfusion, you were doing some benefit to the patient, although at 3-month levels, the MRS wasn't making a lot of difference. But if you see, you can still see that MRS 0 to 2, you're probably still off better doing alteplase without an increased risk of bleeding. So there was some suggestion that that could be done. Then a lot of trials came in and we did a meta-analysis, and we did see that in that meta-analysis, 0 to 1, MRS 0 to 1 was definitely better in the alteplase group as compared to the TPA group. But a very interesting thing came out very recently, especially because those trials were done in the time when EVT was not eligible, right? So right now, if somebody came beyond 4.5 hours and they had a big bad stroke and you could do EVT, you were probably going to get the benefit nonetheless. However, what if you were in a place that was far off? You were in, say, super northern Ontario, and Sudbury or Regina or something is too far off for you to be transported in reasonable time. Or you have blocked carotids and the interventionist can't get to you, can't get to the clot from your carotid artery, or for some reason, like I remember the example that one of my colleagues gave us, you're in a remote island and you don't really just have EVT, right? What do you do then? Should you stop, not even give them TNK? And the interesting thing, what they did see was there was benefit, especially for MRS 0 to 1, that if you did treat these patients from even 4.5 to 24 hours with TNK, if you could not do EVT in these patients, there was still going to be some benefit. So slowly and slowly, we are tweaking our patient population to see if we can treat anybody more than our standard 4.5-hour windows. There's also some active work going on in one of the contraindications. One of the absolute contraindication that we still do is DOAC use, where if you have a patient on apixaban, rivaroxaban, edoxaban, dabigatran. Dabigatran is different because you have a reversal agent for that, and you can reverse it completely and thrombolize these patients. But if you have any of the other three, the apixaban, rivaroxaban, edoxaban, which are much more commonly used, we couldn't really thrombolize these patients. However, more and more data is emerging that if you do thrombolize these patients, the risk of bleedings is still about the same 2.5%, right? Which is what I gave you the figure um, for stroke patients as well, for patients not on DOAC as well. So if you have a very disabling stroke, you can't do EVT, the patient is on DOAC. There is an active trial that we're currently on enrolling in Canada and Europe, where we're testing the strategy. Can you thrombolize these patients and see if there's any improvement? Okay. So with that background, we are going back to Mary. So we did a stat CT, nothing on her CT, no bleeds or anything. We did a CTA, and now this is a cut section of the brain, the CT angiogram. See, this is the one of the major arteries on the brain. It's known as the middle cerebral artery, which supplies about 80% of the front of the brain. On the right side, that looks okay. On the left side, you see there's a cutoff and you can't really see that middle cerebral artery. So she had what we call a left M1. M1 is like the place in the middle cerebral artery. Very proximal areas is what we call M1. Distal areas is what we call M2s, M3s, and M4s, based on how where the location of the clot is along the length of the middle cerebral artery. Now, this patient had an M1 occlusion. Now, could we give her TNK? No, because unfortunately, her last known well was last night. The partner didn't know if she was okay during the night. So she couldn't get TNK. What could we do for her? The next step we have or offer for these patients is what we call endovascular thrombectomy. It's a very specialized treatment. Rhonda, correct me if I'm wrong. It can only be performed at 11 hospitals across Ontario, but that data may be outdated and a few more centers might be able to do it now. But it's still not as widely available. Even in our center, only our center can do it. Niagara, Brantford, Guelph, Waterloo, everybody sends their patients to us. So just imagine, very, very specialized treatment. How is it done? So we remember we're talking about that groin puncture. We go through one artery in the groin. We go all the way over the heart through this curve, and then we take our catheters up to the brain and we try to physically pull that clot out. So we reach our catheters at the site of the clot. We have what we call stent retrievers, wherein we entrap those clots in that mesh of stent, and then we yank it out. Okay, and we hope that the clots pulled out when we yank that catheter out. So just a slightly magnified look of that. We've reached through the groin, through the curve in the arteries in the heart, going up to the brain through the carotid artery or through the back through the vertebral artery. You reach the site of the clot, deploy this stent retriever, trap this clot in, then pull that clot out, and then there you see at the end, that's the clot that we have, and hopefully blood supply is restored to that. I'll quickly show you a video that I pulled off YouTube, which just shows that. So we go in with our stent retriever, so using angiograms. So there's a blockage there. We've deployed a catheter with a stent retriever. Now we wait and see. This patient is describing that her life changed as soon as they pulled the clot out. She was able to move her limbs. So they're able to pull that clot out, and you restore blood supply to that part. So now EVT, who is eligible for EVT? There are three things that we look at. There are patient factors, there are clot factors, and then there are brain factors. Now for patient factors, actually, there's actually no subgroup of patients that does not benefit from an EVT. Everybody benefits from EVT. There's no age cutoff. We've done EVT for a 107-year-old patient too, who was functionally independent, who was mowing her lawn and was gardening and till a day before her stroke. So there's no age cutoff. In fact, in the elderly, there may be actually a bigger treatment benefit, because if you don't restore them back to their functional status, they're more likely to go to long-term care or nursing home, because there's not a lot their own body can do for themselves. There's no comorbidity to definitively exclude. However, what we do ask is that the patient is functionally independent. You don't want to be doing EVTs on somebody who's bedbound or severely disabled, because remember, only 11 centers in Ontario are doing it, or very few centers in Ontario are doing it. If you start treating everybody, there's probably not enough resources that you have for patients where you can actually create treatment effect where they are back to being at baseline, versus somebody who is bedbound. You can't really make them better than what they were before the stroke. So that's why when in the TOA, the typical baseline level of functional independence is so important for us. The next thing that we want to do is when we are deciding a patient's eligibility for EVT is, where is the clot? Is the clot in one of the big vessels? As I said, the MCAs, the basilar, the ICA, or is it in a more distal, like an M2, M3 MCA or ACA, or some of the distal vessels in the brain? When EVT came out, we were so excited that we were fishing for everything. But recently we've come to realize that if we are taking our catheters way deep into the brain, we actually might be doing a lot more harm to the patients. So now we've restricted kind of ourselves to our big vessels, which we call the large vessel occlusions, and some very proximal medium vessels. But we are now more restricted in which patients that we are choosing. Now, these large vessel occlusion patients can often be identified by you at screen, right? The LAM score that you often use. If the score is more than 4, that's a predictor that this patient might have an LVO stroke. As well as something that we use in our own ED, which is the Act Fast tool, to see if these patients, which says, do the arm test. If the arm forms immediately or within 10 seconds of being held up, you check for if the right arm is weak, can they speak? Is they, do they have any language deficits? Or if the left arm is weak, so they have a right hemispheric stroke, are they showing some obvious signs of gaze preference or neglect to one side? And if that is there, then these patients are very likely to have a large vessel occlusion instead of a small vessel occlusion. And these large vessel occlusion strokes unfortunately need EVT to get that, because TPA just doesn't do it as often as it does for other small vessel strokes. So yeah, there are clinical tools that you can use to find out which patient is going to be eligible for EVT. They have good prediction at about 85 to 90%, if I'm not wrong. But the eventual determination is going to be once we do the CT angiogram and we find that big left M1 or a right M1 clot that we see. Now, the third thing we are looking for is that parenchyma, that penumbra. Is there any salvageable brain left? Okay, because if the patient's completely infarcted, so if you have a patient who has a stroke looking like this, where all the tissue is dead, there's no matter if you open that blood supply, nothing's going to change, right? This is all infarcted. This is not penumbra. What you want to be intervening is more likely a patient like this, where clinically he has a big stroke, but the full brain has not yet infarcted and there's still some salvageable tissue. So to determine that, we have something called the aspect score, which is a score out of 10, where a 10 on 10 means very good brain, a lot of salvageable brain, and the lower we go down on the aspects, it means that the brain's not really that salvageable anymore. Now, Rhonda briefly touched on this, so I won't repeat this. So 2015, when the original thrombectomy trials came in, we only were treating patients up to 6 hours. Then came the Dawn and Diffuse in 2018, where we realized that even for 6 to 24 hours, just look at that treatment benefit that you're getting from in patients. So this is MRS 0 to 2 in non-EVT, and this is MRS 0 to 2 in EVT patients. So the treatment effect that you were getting was even higher. The number needed to treat for all EVTs was 5, but in the number needed to treat from 6 to 24 hours was 2. So you just needed to do EVT on 2 patients to get 1 patient to become fully independent, right? The treatment effect was such higher. So at that time came, as again Rhonda described this in detail, so I will skim through this. You were picking patients who had a small core and you had a large penumbra. So small pink area, which is describing the irreversibly infarcted tissue, versus a large green area where you were looking at a lot of penumbra, which is salvageable brain, so dying but not yet dead brain. So you could select a CT perfusion, the ideal patient, and you could treat that. So anybody beyond 6 hours. So our patient, Mary, who was 12 hours from last seen onset, needed a CT perfusion. So this is Mary CT perfusion. So look, 0 core. So no part of the brain was irreversibly damaged, and then a large penumbra of about 75 mils. So a lot of salvageable tissue. So had we been limited to the 2015 era, we wouldn't have been able to treat her. But beyond 2018, we got the CT perfusion. We saw that there was no large core. There was a good penumbra. We took her to our angio suite. So again, this is the main carotid artery, and there we see the left M1 occlusion. And then our doctors went in with the stent retriever, got the clot out, and look at how beautiful that vessel is looking immediately after the first attempt. So they were able to fully restore that. So what's happened new in the EVT world is, however, now we are trying to find more and more patients who we can offer this treatment and who can benefit from this, right? So initially, as I said, the treatment cutoff was for patients only with aspects more than 6. So if patient had a very bad looking initial CT, you didn't really offer EVT for these patients. So as you saw in Rhonda's graph, about 10 to 15, or I forget the number, 10 to 15% of patients who were transferred in from periphery had worsening of their aspect score, and we said, no, there's no benefit, so we don't want to treat these patients anymore. However, in the last 3 years, there was a spate of trials which started looking at these patients, and we were excluding these from treatment benefits, but they started looking at these patients with aspects of 3 to 5. Remember, original EVT only for aspects more than 6. Now we are going lower, and we saw for aspects 3 to 5 also, all the result was favoring EVT. So we said, can we go even lower? So then they started looking at aspects 2 to 5 and even aspects 0 to 5. And there was still signal, not a lot, but there was still benefit that these patients, if you cherry pick the right patient in the last 6 hours, younger patient who's likely to do well post EVT, that you would still had benefit even in these very large core trials. So that's where we are for hyperacute treatment. Mary did well. She got admitted to our stroke unit, where stroke neurologists and intensivists, our allied therapy, OT, PT, SLP, work in tandem. Everybody is taking care of the patient. There's data that if these patients are getting treatment in an integrated stroke unit, they tend to have better outcomes. Once we figure out the cause for the stroke and we have a plan for preventing their next stroke, we send these patients off to our rehab wings, where our rehab physicians do their magic, and patients eventually go home with hopefully a good level of functioning. Now, an interesting thing happened. No, sorry, before that, one thing that my last couple of slides, where when this whole process begins, when Mary had her stroke symptoms identified, a lot of patients ask, what's happening to me? Am I going to be okay? And this is where your role, because when we are in such a rush, we often don't get time to communicate, and that's a problem that we're always working on. But when the first point of contact is you, clear patient communication is very important. I'll give you an anecdote of a colleague of mine who's a stroke internist. He unfortunately met with a road traffic accident, and he came to ED and he was terrified. And he, in his words, he was like, "Am I dying? Am I dying?" And then the EMS crew just tapped him on the shoulder and said, "You're at the general. You're going to be okay." And he said, like, that's the first time I think I breathed easy, when somebody said that. And then my brain, rational part of his brain kicked in. So just these clear, calm, urgent, but reassuring messages. You may be having a stroke. We'll do everything to try to make sure you get help ASAP. But sometimes just the fact that you're going to be okay is to calm these patients down. One thing that the stroke best practice guidelines does recommend is that if you can provide instructions to the patient's family where you're going, either recommend to come in their vehicle to the ED, or be available on phone if we have any questions to them. That's very important for them. Going back to Mary, she had a short stay on her stroke floor. She was found to have new atrial fibrillation and she was started on DOACs. She had a short stay in inpatient rehab. Now she's MRS 0 independent, back to driving and actually volunteering at HHS. So that's the stroke journey that we're looking for. Now, an interesting thing happened while I was trying to find out the stroke unit, a photo for integrated stroke unit. I came across this wonderful video on the HHS website, which actually kind of summarizes this whole talk. So I felt very useless after seeing this video. It's like, why am I giving a whole talk when everything is just beautifully summarized in this video? You may see a few familiar faces, a few familiar patients, but I thought we'll take like
stroke is a serious medical emergency.
2.5 minutes to see
During a
this
stroke,
video.
your brain cells start to die quickly because they're not getting oxygen from your blood. With a stroke, reacting fast is essential. If you think you're having a stroke, call 911 so you can be taken to hospital immediately. Getting to the hospital quickly will improve your chances of making a better recovery. The highly trained stroke team at Hamilton Health Sciences General Hospital will determine if you can use clot-busting medications or a special procedure to help in your recovery. If you're making a better, if you can use clot-busting
medications. So that's the TNK that we're talking about. What they're doing right now is they're going with their wires through the groin.
For procedure to help in your recovery. The stroke team is notified in advance and will be waiting for you in the emergency department before you arrive. Across our region, there are 6 hospitals that work together to ensure everyone can get fast access to excellent stroke care. If you need clot-busting medication, you can get it at all specialized stroke centers in the region. If you need a procedure called clot retrieval therapy, the stroke centers in the region will get you to Hamilton General Hospital. When the ambulance arrives at the emergency department, paramedics will hand over your care to the stroke team. Paramedics give the stroke team crucial information that helps determine what kind of treatment is right for you. You will be assessed as quickly as possible and then taken to diagnostic imaging area for a CT scan. The CT scan will help identify what kind of stroke you have and the most appropriate treatment. There are 2 main treatments for the kind of stroke caused by a blood clot. The doctor will determine which treatment you might receive depending on your stroke. The first treatment is clot-busting medication. Specific drug.
Sorry. Every time I click, something bad happens. So
Medication. Specific drugs help dissolve the clot that is causing the
that's my colleague,
stroke
Dr.
and restore
Katsanos.
blood flow to the brain. The second treatment is called clot retrieval therapy. The clot retrieval therapy.
This is the angio suite where all the magic happens, where they go with catheter. Oh my God, sorry. Where they go in with catheters and they try to put.
The
they're
clot
looking
retrieval
at
therapy
with
procedure
X-rays.
requires highly specialized staff and equipment.
They're looking at X-rays to see, and then they use these guide wires to position themselves right. We're in blood vessels in the brain. It's a very niche, specific thing that patients are able to do. That some of our physicians are able to do, and
It's cut off to the brain, millions of brain cells die. So when a stroke is suspected, it's very important to call 911 immediately. Paramedics will begin care and ensure you get to the right hospital as quickly as possible. Learn more about stroke symptoms and how you can lower your risk of stroke.
I thought that was a very wonderful video with some of our very own people. I just wanted to end by thanking all of you for letting me speak today, and just thanking all of you for everything that you do. I cannot stress on the importance of that enough, how important it is for us to make our treatment decisions based on everything that we get from you, and how important that is in this patient stroke journey.
Yes, and thank you.
Yeah, sorry, that went longer than I thought. I think I took more time, but I still have about 10 minutes for questions. So
so please, anyone, feel free to put it in the chat, or you can raise your hand if you'd like. I'd like to ask a quick question, Dr. Shrivastava. I wonder if your slides or any portion of your slides might be available to the participants. There's lots of practical information.
Of course, I can send it out to you, Tina, and you can share it with everybody here.
Okay, that's great. Thank you.
As long as Steph and Rhonda are okay with it, because that's the only two people that are there in the slides.
Just give people a minute if you want to type something.
I think this is why in-person meetings are just so much. I have no idea if people were listening. I have no idea if people got anything what I said. I have no idea if anybody, if I was talking too fast, if I was talking too slow, if I gave anything useful, if I gave everything useless. Yeah. And a couple of years back, we did have it in person, right? I think we need to go back to that. Oh, thank you. Somebody was listening. I'm very happy.
Yeah, so there's some comments in the chat appreciating the information. We were listening. It was very informative. Thank you. It was very informative and well laid out, easy to understand. Thank you. Definitely listening.
I've also seen a lot of times our EMS crew, if time permits, they often hang back a little bit just to see the patient stroke journey. If you're ever around HHS, feel free to ask whoever's on call if you want to see the actual clot busting, or if you actually want to see our EVT suites, it's sometimes much more exciting to see that in person.
We do have a question from Jason. Do you anticipate the 6-hour window for EVT for pre-hospital transport to be expanded to 24 hours?
I think Rhonda briefly touched on that. So we have that 6-hour window as a hyperacute window based on the 2015 trials, right? From 2018 onwards, we did know that what the protocol is. Once the patient comes to ED, the ED physician screens them with that ACT fast tool. They think if it is looking like an LVO, get the CT, CTA, CT perfusion. And then if the CT perfusion does show that these patients are meeting criteria, they call us and immediately activate everything going on. However, just towards the end of my slides, I did start talking about we may be heading to an era where even patients who didn't traditionally meet the CT perfusion guidelines now are going to do well. Of course, we cannot take everybody in, but there is that a few select population who even despite advanced imaging, we might just need a plain CT CTA to see and pick out those patients who will benefit. So yes, I do think eventually this era is moving towards a world that up to 24 hours, if you have a stroke which seems like a big bad stroke, more often than not, you're likely to end up getting that procedure.
And more thank yous. I've taken a lot of notes from the presentation.
I think Steph and Rhonda have to add to that. They're working
okay.
this round.
No, I'll hand it to Rhonda for because I think that Rhonda is going to speak to your comment. I had a different question, Dr. Serviceva.
Oh, okay.
Yeah, so one of the things we've been looking at since the paramedics have been using the LAMS up to 24 hours, as Dr. Srivastava said, we know a LAMS 4 or 5 are highly probable that the patient might have a large vessel occlusion. And we know right now the paramedics take the patient after the 6 hours to the closest hospital. So we're doing some work to say, we know we have this advanced imaging at all of our centers. Should we be changing that destination protocol to have the patient go to the closest stroke center to get that advanced imaging? And so that is something we are working on for LAMS positive patients in the 6 to 24 hours to go to the closest stroke center where they can get that imaging to identify patients who may be eligible for EVT in the advanced window. So certainly something that we are hoping to move forward in the next year to get to those closest stroke centers. So great question.
Mm-hmm. Go ahead, Steph, if you've got a question.
Thanks, Dr. Serviceva. A wonderful presentation. I'm just wondering if there's any new. I know we've just made the switch to tenecteplase, but I know you're very aware of all of the current evidence and trials ongoing. Is there any new clot busting type medications that are being studied right now that may have a future in hyperacute stroke therapy?
Yeah, very good question, Steph. I think once we've got the tenecteplase, we all kind of relaxed a bit. And it's like, okay, now we have our golden drug, and we don't need anything else. While people in China did do one more trial that was very recent, I think came out end of 2024 or mid 2025, that tested another sister molecule. The concept is still the same. So tissue plasminogen activation. We had the alteplase, we had the tenecteplase. They tested something called a reteplase. Okay. Again, very similar. The benefit again is more fibrin specificity to supposedly more clot specificity and slightly less bleeding. They did show that there was maybe a signal for lesser bleeding with reteplase as compared to alteplase. They tested it with alteplase, not tenecteplase. It's just one trial though, and it's not really gained a lot of popularity and acceptance because it was in a very exclusive Chinese population, and we don't know how well it will translate to our side of things. There are some things that we're still checking in tenecteplase itself, right? There's an ongoing trial to see if we have the best dosing of tenecteplase available. We're doing the 0.25 milligram per kg, but can we safely do a lower dose? Will a slightly lower dose improve the bleeding risk while keeping the efficacy? So there's still a lot of things that we are tweaking in tenecteplase that's happening as we are speaking. And I think the next frontier that we've gathered from trials in the last couple of years is going to be a new class of medications, which is neuroprotectant agents. So while we are trying to get the patient to the nearest center, and we are trying to get these patients with the clot busting treatment or the EVT, can we give them something pre-hospital to kind of freeze their brain, or kind of keep their brain in status quo while they get their treatment, and once they get their treatment, blood supply is frozen. So to limit the actual core. So that's the next era of treatment that they're looking at. Nothing's been positive so far, but there's a lot of promising signals.
Thank you. There's a number of other thank yous and also some takeaways. One last question. If someone was brought to a local stroke center, they did not meet the 6-hour symptom onset bypass, say they were actually around the 24 hours, but stroke center was still closest, and they had a LAMS score of 4 to 6 and not treated as a stroke alert with immediate CT, what does their treatment look like through the ED?
Fantastic question. And I'll address very quickly two parts to that question. One is that 24-hour thing also sticking, right? And what we are now slowly realizing is it may not be so much as a clock 24 hours, but it's more like a tissue 24 hours kind of a thing. So if patients who don't have a good last known well, or if the last known well is a little older, 24 hours, say they came at 26 hours or they came at 28 hours, should we exclude them from all treatments? And we're realizing, no, we still do the same things, the CT perfusions or just the plain CT-CTA, look at their aspects and see if there is salvageable tissue. So what we're looking more instead of time is now the tissue. If there's salvageable tissue, you go ahead and treat. In ED, however, what happens is as soon as, even if they're at 24 hours and if they come in with a big stroke, the ER physician is immediately there may not be a pre-stroke notification and we may not be called, but the ER physician is there immediately at the bedside. As I said, you've done the LAMS and they do their act fast, and they think if it is an LVO, they immediately get the stat, CT-CTA. Sometimes they even call us that, look, there's a potential patient in the extended window. Just keep an eye out for the imaging, because we get the rapid on our phones way before that they get the call from radiology. Look, there's some patient that has it. And we keep an eye out. And as soon as we see that there's some salvageable brain tissue on their imaging, we kick in the same stroke protocols.
Okay. Thank you. We are after 11. There isn't one more question. I wonder if maybe we can pass that to Dr. Salas as part of his Q&A. And thank you again, Dr. Shrivastava. Just excellent. And you can see by the comments, people got a lot out of your presentation.
Thank you, everybody. Thanks for listening. Makes my day.